Hi, everybody. Thanks so much for coming along. So I'll just give it a few minutes as ever and let a few people trickle in. I'm sorry for coming on a couple of minutes later today. So we're going to be looking at a couple of different things today. So we'll talk about communication skills primarily to begin with and look in more depth into bad examples of communication, good examples of communication. Then I've got a couple of cases to go through together, and then a few MCQ questions. So what I'd really love is for this session to be as interactive as possible. Put some things in the chat, because if it's just me asking a question to the air and getting silence back, then it won't be a lot of fun for anybody. A bit of a disclaimer is that I'm a bit poorly, so if I might have to stop at points for a cough or to blow my nose, so I'm sorry about that. But we'll power through regardless. So while we're just waiting a minute for people to trickle in, I'll flag up the next session is tomorrow, same time. We'll look at children and elderly LGBT healthcare. This was a session that was supposed to be on last Wednesday, but we had to delay it. So you can find the link for that on Medal. You can find it on Mind the Bleeps Facebook page as well, and on like the F1 WhatsApp chats. If you've gotten links off there before, then they're on there as well. So yeah, do go and sign up for that one as well. So like I said, just give it a minute or two and then we'll go through. Can you just send a yes or a thumbs up in the chat if you can see and hear me all right? Actually, I just realized you might not have heard anything yet. Am I coming through to you all? Yeah, brilliant. Okay, thank you very much. All right, I'll just give it a couple of minutes then and we'll get started. Okay, so yeah, let's get going then. So as I mentioned, next session is tomorrow, and then this is the list of sessions. We've had a bit of a rejig. People's commitments have changed a little bit, so it's a bit different to the list that we put up in the previous sessions. So after tomorrow, next Wednesday, we'll have social factors, mental health. Then we're revisiting the dermatology session, which was cancelled from a couple of weeks ago. And then our last couple of sessions. So yeah, just keep an eye out. There oughtn't be any more last minute changes, but you never know. So I just thought I'd keep you aware of that. And then this screenshot is obviously where you can find the link to register on Medal. That's what it looks like. There's a little like register here button underneath. So yeah, do go do that if you're interested in tomorrow's session. All right, so what are we going to cover today then? So we'll look at basic communication principles first. So this is specifically for dealing with LGBT patients, but frankly, a lot of it is relevant to any patients. I think you'll see by the end that the main header is being polite and being kind and considerate. So it's something you can bring forward when dealing with all patients. Look at a couple of cases. Then I think I've got 10 MCQs or so. And then if you've got any questions for me at the end, then I'm very happy to answer. So let's start off with communication. So introducing yourself. That's the first thing we do when we talk when we see a patient, when we see anybody, a colleague as well, or a family member. The first thing I'd say for LGBT patients is you'll be aware of getting their name and their pronoun correct is one of the most important things. Now, obviously, this isn't as relevant for every single patient. I think I mentioned in my session before. Say, for example, you're on a geriatrics ward. Just statistically, you're less likely to be a patient with pronouns that you wouldn't expect just from what they look like. But that doesn't mean you can just go ahead and assume. So, considering their name and pronoun, and then asking if you're not sure. Also, have an awareness that it's not always going to be the same as what you've seen online on their system. It might not be the same as what you've heard other people call them. They might have a way they want to be referred to that other people aren't aware of yet. So it's always worth just asking yourself. We did cover a lot of terminology in previous sessions with regards to like what transgender means, what cisgender means, non-binary people, etc. I wasn't going to go back over that today, but just to check, let me know if it would be helpful to quickly run over those things, because obviously it is relevant. As things like asking name and pronouns is more relevant for the transgender population than the cisgender population. So just let me know if you want me to talk about that a bit more. So other things about introductions then. Use open questions when doing introductions. So say, for example, we see a patient with an F marker on their records. I'd say one of the worst ways you can begin that conversation is going, is your title Miss or Mrs.? Because that's a really close question. You've given them two options to choose from, and their title may fall outside of that. I mean, their title might not be gendered. It could be doctor, it could be captain, you know what I mean? So it might not necessarily fall within your kind of two expected options. So use an open question. Ask them what their title is. You could ask them what their gender is or their gender identity. That would be a far more open way of bringing it up. In terms of asking their title, it is it might feel like a more comfortable way of bringing up someone's gender compared to asking their pronouns, which can feel a bit kind of all of a sudden a bit blunt. However, asking what title someone uses is kind of an odd question if you're not doing administrative forms or something. It's not something that tends to come up every day. But what does tend to come up every day is how would you like me to refer to you? And I'm sure this is something you'll have looked at when you're treating older patients again. Often, older patients would be preferred to be called Mr. and Mrs. whatever, whereas younger patients would be happier or more than happy with their first name. I mean, personally, if I was called Mr. Letten or Dr. Letten by my doctor, I would feel very good. So open questions really is the thing to handle. So I've got a bit of an example here. So this is our doctor who's going to appear throughout the next few slides. So he says, "Hi, my name's Dr. Jones. Is it Emily? This is our patient." And the patient says, "Actually, that's not the name I go by." So at this stage, if you were Dr. Jones, what are you thinking? What's gone wrong? What are you going to say next? Any ideas? How can Dr. Jones salvage the situation? Trying to hear, not sure if it's my system or yours. Oh, okay. Let me just check. Is this any better? Can you hear me any better now? I suppose I should keep talking to make for you to see if you can hear me better now. Well, so what does Dr. Jones say in response? Apologies. What name would you prefer? I think that's a easy way to get around the problem. They've clearly done something wrong, but they're being open about it. They've Okay, good. So sorry about that. I'm not sure why you couldn't hear me. Kept cutting out intermittently before. Oh, that's annoying. I'm sorry. Okay, at least we're back on track now. Yeah, so they've asked an open question. They've gotten rid of any assumptions. The worst thing they could have done is kind of hammered it home. When the patient goes, "That's not the name I go by," and then Dr. Jones would go, "Oh, well, that's the name I saw on the system." I'm pretty sure. I remember last time you came in, you were called Emily. That's what I called you that time. That wouldn't be very polite and kind. All right, let's move on to the next bit then. So history taking. Again, when we're taking a history, we're using open questions, and this is the same for everybody. Obviously, we've got that golden minute. Just let the patient talk, and don't interrupt them for that minute. A key thing is to allow plenty of time for LGBT patients. If they might be coming to you with a like queer health related issue, in which case it was going to be sensitive. They might not have spoken to someone else about it before. If you can give them longer than your average patient, if it feels appropriate, then do. Or in fact, just give them more time when they're speaking rather than cutting in. Cutting in whilst you might be doing it as politely as possible and you're aware of how little time you have with the patient, that can seem immediately just rude, disinterested, but it may well come across as judgmental, that you feel negatively towards LGBT people and therefore you don't want to hear it. And once you've done that and the patient has that view of you and that concern, then you've gotten rid of any kind of rapport, any kind of doctor-patient relationship you were trying to build there. So don't assume the gender of their partner. That's another key one. So use neutral language before you get confirmation. So use they, them, or use partner and referring to their significant other. And also just echo the language that patients use. So if they use partner or they use husband, use the same term. So if they use husband and it was a female patient, for example, this is like stereotypically what you'd expect, right? A man and a wife. And so you would just automatically echo it. You'd be unlikely to switch back to partner. So if we've got a situation where a patient doesn't use husband or wife, but uses partner, just stick with that. Stick with what they've said. Similarly with language, the language that a patient uses to describe themselves is really important. And whilst on paper words have specific meanings, the identity that every individual person has for themselves can be really personal. So you might think that the term gay and homosexual is synonymous, and to you that's what they mean. But if a patient refers to themselves as gay, for example, don't later down the line tell them they're homosexual, because that might not encapsulate what they meant by that. So just echoing that language that they use. Similarly with the language for a partner, by keeping it neutral, we are avoiding forcing a patient to effectively come out. So if we had a male patient, and we reference his wife or his girlfriend, he then has, and assuming he's gay, he then has two options. He can either just go along with it, and then he kind of weirdly lying by omission and probably feels a bit weird that you've assumed this about him, or he's got to come out to you and say, "Oh, actually, I've got a husband." And this is a common misconception about coming out as well. It's not one big event, and then everybody knows. You're coming out all the time to everybody, and it's these kind of assumptions that means it's always happening, basically. And then thinking carefully, is this question relevant? So whatever you're asking them during that history taking process, just make sure that it's actually got to do with the health problem that they came in for. Sorry, I've just lost you. Yeah. You don't need to be asking them about their sexual orientation history, or about their surgeries they've had because they're transgender if they've come in for just asthma. Okay. So I've got another example. So this is our patient, and she says, "My wife said I was sleeping more than usual." How should Dr. Jones respond to this statement? Is there anything specific that he should say? So not really. Nothing at all. She hasn't said anything particularly noteworthy. Yeah, match the language the patient uses, definitely. So he could echo it back, ask more questions about what the wife has noticed. Maybe it's relevant to the presentation. What about if he says this? Is that? I think that's quite an extreme example. Do we think that's an appropriate thing to say in response? No, certainly not. Yeah, it's just incredibly rude. Could you tell me more about that? Yeah, definitely. Just asking more information, like any history taking, because it's so like irrelevant, if you will, that she has a wife or she has a husband. Okay. So then examining. So communication when we examine someone, especially if it's intimate, is paramount anyway. First thing, explaining what needs to be done and why. So again, if it's intimate or if it involves taking off items of clothing, explaining why you need that kind of exposure. Offer a chaperone, again, especially if it's intimate. I mean, if the patient seems anxious, it may feel appropriate to offer a chaperone even for examinations that aren't particularly intimate. But if they are examining like a rectal exam or a breast exam, something like that, then have a chaperone in the room. Make it very clear they can ask you to stop at any time and arrange how they will ask you. So either they can just say to stop, but if you're examining the mouth, for example, then there needs to be a way for them to sign that they need you to stop, maybe putting a hand up. Considering the environment you're in as well. So environment on the ward is really difficult, right? Because we draw these curtains around and it gives the illusion of privacy, but the curtains are not remotely soundproof. And behind them, you can be discussing all kinds of intimate things, but if you're discussing things to do with someone's gender or their sexual orientation, or using particular terms that would allude to differences in that patient to anyone else in the bay, for example, then what you've done is outed somebody without their consent, most likely, and made everybody very uncomfortable. So just be considerate of that. So, I mean, firstly, we need to be discussing language and terminology anyway, as the final point says. We need to be using terminology that patient is happy with. Therefore, when we're behind the curtain, actually the terminology we're using may not sound unusual, say for a trans woman who's in a female bay. We might be using terminology that makes her the most comfortable and therefore doesn't raise any eyebrows from anybody else who can hear. But it might be wiser to just go to a side room if there is a side room available, if you need to have this kind of intimate conversations or an intimate examination, so that you're not outing the patient to everybody else. So Dr. Jones, so he's seeing an elderly cis male patient. The patient's had his golden minute. Dr. Jones has asked a couple of follow-up questions. And then he says, I need to perform an examination of your back passage, so just pop behind the curtain and take your trousers and pants off. Any feedback about this request from Dr. Jones? Do you think maybe he could say a little bit more? Assumed consent. Yeah, that's a very good point. No explanation, no consent. Yeah, exactly. And so this is our patient here, and that's what he's thinking. He hasn't explained. He doesn't know what's going on, why this is appropriate. Maybe this patient has come in with difficulties urinating, and it doesn't make any logical sense why he'd want to look at his back passage. That doesn't match up to the patient. Exactly. And he's just assumed that the patient's going to be happy with this. So we need to be explaining properly. And we haven't offered a chaperone in this example either. Okay. So referrals. So when we're doing written communication, when you make a verbal mistake, it's easily fixed. You can apologize and move on. Slipping up on written communication means it's going to be there all the time. You've sent some inappropriate writing to somebody else. So now there's multiple people who are both aware of your mistake or going to make another mistake in the future because you've gotten it wrong the first time. And you need to be aware you don't automatically have consent to share someone's gender history or their sexual orientation. You need to ask the patient. It doesn't need to be a particularly like a big fanfare of a question asking them if you've got consent to share it. Just it can be very simple, and patients will more than likely say yes, because if you're needing to share it, then it will be relevant to the presentation. So they'll want whatever future doctor or nurse they're seeing further down the line to have all of the facts at hand, right? So just ask the patient that they're happy for you to share everything. So Dr. Jones is seeing a patient, and this is what he asked. I'm going to write your referral letter to the gastro team. Would you like me to share your preferred name and pronouns? Any feedback on Dr. Jones' question? Does he need to ask anything else? Personally, I don't think so. I think that's respectful. He's explained the context of why he's asking. It's for this referral letter. And he hasn't as well said, can I share them? He said, would you like me to? So I feel like that subtle difference leaves it even more in the patient's court. And also it feels almost more supportive, because if the patient knows they're going to have to go and see this gastro team, separately come out to them and share their preferred name and pronouns in the future, this just gets the job done. Like, it's already done before they get there. So there's going to be no issues by the time they arrive. Okay. And then non-verbal communication then. So there's actually a fair amount of this to think about. Non-verbal communication is particularly important for queer patients, a bit like I mentioned earlier, because they're likely to be hypervigilant to even the smallest like negative vibe from you, probably because of previous experiences or just because of high anxiety, because they're aware of what others have been through when interacting with doctors and the health service in general. So the first one to think about is that neutral facial expression. Stay neutral, or like smile a little, but avoid frowning at the wrong time or looking maybe confused if they're discussing aspects of sexual or gender history. In terms of your posture, make sure that it's open and engaged, just as you would for any patient. But again, have an awareness, you're not to get distracted on your computer or turn away to do something when they're talking about something more personal. It might be normal to be typing some notes or prescribe something at the same time as the patient talking, and you know that, but the patient doesn't necessarily. And to them, it may well come across as a lack of interest or you judging them. Eye contact. Again, hold good eye contact. If there's multiple people there, switch your eye contact between both people to show that inclusiveness, because the patient's clearly brought that person as moral support, right? Your tone and your volume. So be careful not to show surprise when patients mention things. Just keep that neutral as well. Also your speed. It can be really tempting, especially if you're anxious, to rush through things. And whilst you might be rushing because you've got limited time for that appointment, the patient may read that as rushing because you don't want to be having this conversation. So if you can, just, as we said before, leave that extra time, slow things nicely down. And if you're worried about any of your reactions, then practice it. Practice the communication with colleagues that you trust, or just with like a friend or a family member that you trust. Practice having role play conversations with LGBT patients. And then if you make a mistake, so if you make a verbal mistake, acknowledge it, apologize, say sorry, and then just move on. You don't need to make a massive thing of it. So Dr. Jones is making a mistake here. You could always ask your husband to help. Oh, sorry, I mean your wife. You could ask her to help. How do we think he did in terms of slipping up and then accounting for it? Any feedback? Would you have said more, do you think? It's not a trick question, I promise. Someone give me a thought. He corrected himself but didn't make it a massive deal. Yeah, exactly. He corrected the mistake, said sorry, and then they just cracked on. If you make it a big deal, you just make everyone feel awkward and waste time. So yeah, I would agree. I think this is a great example of responding appropriately. Okay, let's move on to some cases now. Does anyone have any questions about anything we've been through already? Other communication questions or I don't know, personal experiences in terms of communication they want any help on? Anything at all before we move on to cases? No. Okay, good, fine. So this is case one about Henry. So Henry is an 18-year-old patient seen on the ward round in acute med. He presents with an intentional overdose of his partner's medication. There's the medication there: venlafaxine, quetiapine, paracetamol, ibuprofen, lamotrigine. The online system says Alison and says female. However, it states that he'd like to be called Henry. He's been started on IV fluids and admitted for monitoring of his QTC interval. Okay, so this was a real case, this one. Has anyone got... Actually, no, I won't ask that. So we'll just move on to the next part. So he's in acute med. He's been seen in the ward round. However, he suddenly becomes very agitated, shaking and restless in the bed. He's got marked pressure of speech. He's having visual and auditory hallucinations, and he declines examination at the ward round. Anyone got any thoughts at this point or any concerns about what might be going on? Any thoughts about next steps? I'll give you his observations. So those are his obs. So rest rate a bit up, heart rate a bit up, temperature's up. He's saturating a little bit low. Blood pressure looks okay. Anyone got any thoughts as to what's going on here? So just from the obs, you could have a couple of ideas. Pretty high temperature, tachycardic, tachypneic. What do we think? There's a big one we probably want to rule out first. Serotonin syndrome. Yeah, that's a good thought, definitely. When we think about what he's taken, let's go back and have a look at what he's taken. Yeah, venlafaxine, took the quetiapine as well. Yeah, any other thoughts? What might be happening? And his symptoms as well, the visual and auditory hallucinations, marked pressure of speech. Okay. So, I mean, firstly, I'd be concerned about sepsis. He's got a very high temperature. His blood pressure isn't too bad, but that's not a good enough reason to suggest that it's not sepsis. So I'd want to initiate the sepsis 6 whilst thinking about my other diagnoses as well. So I definitely think about serotonin syndrome at this point. We could also consider just psychosis at this point with those symptoms of the marked pressure of speech and the hallucinations. So we do a blood gas for him, and this is what it comes back as. So lactate is up. It's gone down a bit since last night, but it's still up. And his potassium is pretty low. Any explanations for that low potassium that you can think of at this point? Any clues in what he took, maybe? So the quetiapine. So the quetiapine can cause hypokalemia. So that should definitely be taken into account. When he came in, he had 2.97. So you'd have to check your trust guidelines, whether that's Sandicay or whether that's putting a bag of potassium up, and also think about how unwell he is as well. He's agitated, restless in the bed, having hallucinations. Would he tolerate oral medication? I think probably not. Okay, let's move on to what happens next then. So the patient's hypokalemic. Why am I worried about the QTC? So if I do an ECG for him, what's the relevance of the QTC? Any ideas? So QTC can be prolonged if a patient's got low potassium. So we need to do an ECG, multiple ECGs while his potassium's low, to ensure that it's not prolonged. But here comes an issue. Do we use a female limit or a male limit? Any ideas which limit we should use for Henry? So the male limit is 440 milliseconds, whilst the female is 460. So it's pretty important, because if we're choosing the wrong one, we'll have a false idea of how unwell he is, and what kind of prognosis he has. So what would you go for, the male or the female limit? Female. Yeah, definitely. So whilst it feels kind of upsetting and wrong that we have to use a female limit for this trans man, we think about what physically the patient has. Because Henry is pre any kind of hormone treatment, any kind of surgery, the female range would be most applicable. There's very little evidence into what it is that impacts the QTC in terms of why men and women have the different limits. There's a small amount of evidence suggesting that it's testosterone. So after a patient's been on testosterone for a few years, we probably go for the male range. I mean, it would be, there's not a lot of evidence behind it, so it would probably be kind of personal clinician choice. Hopefully, it's pretty clear, and either the patient's QTC is not remotely prolonged, or it's stonkingly huge, in which case you have an idea of what's going on. So yeah, we'd use the female range for Henry here. Do we need to examine Henry? Well, if we do, so say we're going to examine him, what do we need to make sure we're doing when we're examining him in terms of our communication? A couple of things we mentioned earlier when we talked about examining. Communication throughout, explaining what we're doing and why. Yeah, completely. Communication throughout as well, especially with this patient where he's agitated, distressed, remaining in communication, trying to keep him calm is really important. Explain why we're doing it will just cause more distress if he doesn't understand. Yeah, reassurance, exactly. Offering a chaperone as well, getting consent at like every single step. So, you know, can I listen to your chest? Yes. Okay. Can I put my stethoscope down the top of your shirt? Yes. Okay. Can I put my stethoscope on your back? Yes. So every kind of little bit, just to ensure we have consent the whole way through. Yeah. So there's that. Okay. So on examination, heart sounds normal. There's a right lower zone, reduced air entry, and it's dull to percussion there with increased vocal resonance. He's got no wheeze or any other added sounds. And we get some bloods back as well. Do you notice anything in the bloods to be concerned about? There's a couple pretty high numbers there. CRP, white cell count, and neutrophil count. Yeah, exactly. So big CRP, big white cell, big neutrophils. And here is his chest x-ray. Any thoughts on that chest x-ray? High inflammatory markers. Yeah, thank you. Anyone spot anything on the x-ray? So I'd say there's something going on there. Right-sided consolidation. Yeah, I would agree. I don't know if you can... Yeah, right lower zone of pacification. Hopefully you can see my cursor. But around here, it doesn't look the same on this side. Sorry. Apologies. Oh. Yeah, so it doesn't look the same on this side, does it? So what actually happened with Henry? What was going on? So he got an eventual diagnosis of pneumonia, probably an aspiration pneumonia. So neuroleptic malignant syndrome can cause aspiration pneumonia due to the increased secretions and the seizures, although in Henry there weren't any seizures witnessed. So potentially happened before he came in, but it's we don't know for sure. It might have just happened when he was in the bed space and there was nobody there. So there are possible elements of NMS, possibly serotonin syndrome, like we mentioned earlier. Currently, he could well just be delirious from the pneumonia. That could be what's causing the hallucinations, the agitation, or in fact, it could be a primary psychiatric cause of agitation. So it could be like mania or psychosis, like we mentioned earlier. So for this patient, it was a bit of a mystery. And in fact, we never fully understood the primary cause of the aspiration. He was given antibiotics. As time passed, his inflammatory markers went down. He improved. And he then was offered the opportunity to see psych. So he becomes calmer and more appropriate after 48 hours, remains low in mood, suicidal, and auditory hallucinations. He agrees to an informal psych admission, but only to a male or gender-neutral bed. What do you include in the letter of referral? So give me a couple of points you just put in the referral letter. Obviously, we need to cover what happened whilst he was in hospital. But anything specific to his gender or his sexual orientation? Okay, so as we mentioned earlier, we need to be asking the patient if we're happy for his trans status to be mentioned. And in this circumstance, I think that would be very appropriate. As the doctor, I definitely want to mention it to ensure that he's treated correctly when he's in the psych ward. So we obviously need to check with Henry, though, that he's happy for that to occur. So this is basically what the referral letter included. So introduces saying he's an 18-year-old transgender man, admitted following X. And then in that middle paragraph, look, he identifies as male, should be referred to as Henry using he, him pronouns. This has been consistent throughout his admission, regardless of mental state. So making it really clear. And what I really like as well about that referral letter is he identifies as male and should be referred to as Henry. It's not he prefers to be referred to as Henry, or he's asked to be referred to as Henry. It's you should do this. It's like exactly what is required. There's no arguing with it. Okay, that's the end of the first case. Does anyone have any questions about it or any comments at all before we move on to the second one? Okay, well, I'll shift on to the second one just because I'm aware of the time. So case 2. So this is Emma and Sarah. So Emma and Sarah are a married couple in their 30s. They visit a fertility clinic to explore their options for starting a family. They're given 2 leaflets when they arrive. One is called Prospective Mother and the other Prospective Father. What's the really obvious big issue here that we see? And how do you think it's going to affect them as they go through their journey? I'm sure you all know what I'm alluding to. Okay, so yeah, it's these 2 leaflets, isn't it? So yeah, okay, thank you. So not applicable to their situation completely. Father won't make them feel included in their own healthcare. Yeah, completely. Which out of Emma and Sarah are going to be the father? That's not how that works. Not appropriate at all. And to think that, you know, in this example, what happened? They came through the door and the receptionist or the nurse or whomever was getting these leaflets, picked them up their respective shelves and handing them over and thought that that was an appropriate thing to do. Baffling. So it's going to affect how welcome they feel in that fertility clinic now. They've just arrived for their first appointment. What a rubbish way to start this process, right? And what should they do? Well, as the patient, what do you think you would do in that situation? Would you say something? Well, you could do, couldn't you? But sometimes it probably feels like it's not worth a point. It can feel daunting to speak up. Yeah, definitely. You don't want to cause a fuss. You don't want to kind of put too much awareness on you. You already feel like you're not welcome. And so, whilst we can hope and assume that we're in a kind, loving society, what if you speak up and then you are suddenly on the end of abuse? So, what are the options then for Emma and Sarah in having a baby? There's a couple of different ones. Could you pop in the chat? What are their options? So, the two main ones would be IUI and IVF. IUI being intrauterine insemination and IVF in vitro fertilization, right? And so both of those could be with either mother, so using either one's eggs, but they would need a sperm donor. And the sperm donor can be sourced through the clinic, and they usually have connections to one or multiple sperm banks. Some of these sperm banks patients can go online and kind of browse through. They can filter by all sorts of categories, even see pictures or hear the voice of certain donors. There's other sperm banks which kind of give you fewer options. So there's a Manchester sperm bank where you give them your like requirements or the things you're looking for, and they send back two potential like profiles, if you will. And then if you don't like either of those, you can request some more, but they kind of limit how much you see at any one point, basically. They could go for home insemination, which is just where they buy the sperm online. It gets delivered to them, and then they do the insemination themselves. It's important to be aware, though, that if the couple who do this are not married, then the other partner will not automatically become the legal parent. And in fact, the sperm donor would be the legal parent of that child, along with whichever partner eventually became pregnant. Whereas if they are married, so in Emma and Sarah's case, then it would be automatic. They'd both be legal parents. Okay, let's get back to our case then. So they begin the process of IUI, and first Emma must undergo fertility tests to ensure there are no problems with her fallopian tubes. She's given injectable hormones to stimulate her ovaries. So there's hormones to suppress the normal production of fertility hormones. Then they might be given gonadotropins to stimulate follicular development. And then about 36 hours before insemination, then you're given HCG to release mature eggs from the follicles. Okay. But 2 weeks into the process, Emma visits the GP. She presents with abdominal pain, and her abdomen feels more distended than normal. It's never happened there before. It came on gradually. She doesn't have any relevant past medical history, no drug history other than her hormone treatment and her inhaler for asthma, and she's just got an allergy to plasters. Any thoughts at this point? What might be going on? Or just what would you do next if you were the doctor in this situation? So I think if I was a doctor in this situation with this presentation, I'd examine next. So these are her examination findings. So pulse a bit high, respirate a bit high, heart, lungs, CNS, nothing interesting. And then that's her abdo exam. So it's distended, she's got tenderness. Sorry, I'm supposed to say in both lower quadrants, right more than left. A shifting fullness is present. Okay, and then what would you do next then? So we've got these examination findings. We know how presenting complaint. What would you do next? So it may well be appropriate to do a pelvic exam. So she made admission for OHSS. Yes, nice. Okay, so this could well be where that's going. So OHSS is ovarian hyperstimulation syndrome. I like your thinking. So let's see what the pelvic exam finds. No vaginal bleeding, normal size uterus, bilateral adnexal tenderness. So she goes to A&E, just like you suggest, and they do an ultrasound, and this is what they find. Does anyone recognize what this is? Or know the fancy like radiology term for it? That's okay. To be fair, Sinead did get there already. So yeah, exactly. It's OHSS. So with the hormone treatment designed to like induce ovulation, it can also lead to the upregulation of vasoactive substances like VEGF. This then increases the membrane permeability, leading to like an intravascular fluid loss, causing like ascites, causing oliguria. You can end up with acute respiratory distress syndrome. Interestingly, you can become relatively immunosuppressed as IgG moves into your abdominal cavity and away from the blood vessels. So if it's severe, really quite scary, but hopefully can be caught early enough. Any ideas about management then? So it can be managed as an outpatient, but what would you advise a patient to do? So of primary importance is to stop the hormones, right? Stop the hormones, drink lots of electrolyte-rich fluid. The patients can have paracentesis to drain the abdominal fluid. And then if it's not improving as an outpatient, then they can be admitted and looked after as an inpatient until things improve. And stay away from like strenuous physical activity as well. Okay, so when the hospital write the discharge letter for Emma, they should be sure they're referring to Sarah correctly, as we've said already. It may not always be appropriate to ask. So what I mean by this, what sign is present on the ultrasound? It is called spoke wheel. I'm pretty sure something like spoke wheel sign. And you see it not just in the ovaries, but you can see it in the kidneys, and I think it's a certain like glioblastoma, but don't quote me on that. So what I mean by whether or not it's appropriate to ask is if we know that they're married, as we do in this case, then Sarah is Emma's wife, and it's as simple as that. Like if you had a husband and wife, you wouldn't double check how you should refer to the husband, for example. But if you don't know, then you should be asking, basically. So what should we include on this discharge letter? So again, obviously we need to describe what's happened when she came in. Anything else? So I'll put it up. I'll put up what was written. So there's the brief overview. I won't read it out. Explains what happened, the background, safety nets. But you'll notice that actually I haven't referred to Sarah at all here. Do we need to? Do we need to refer to Sarah in this discharge letter? No. Yeah, I think I'd agree with you, to be honest. When would it be appropriate? Maybe if the patient, well, it's going back to the GP. So maybe the GP doesn't know the patient very well. Maybe Emma has voiced that she's concerned the GP will make assumptions, and so she'd like you to mention that they're in a same-sex couple. But I mean, frankly, the GP saw Emma a couple of days ago with her OHSS. So I don't think for it. Yeah. So what happens next then for Emma and Sarah? So it's 6 months later, and Emma and Sarah are ready to have another go at trying for a baby. This time they decide that Sarah will carry, and after 3 rounds of IUI, she has a positive pregnancy test. They attend their 12-week scan. What do you think I'm going to see on their 12-week scan? That's quite a broad question, is it? What might I see that isn't nicely and simply just a baby? So what I could see is 2 babies. So the chance of multiple pregnancy with IUI and IVF is greater than without any like fertility enhancements. There is also a risk of ectopic pregnancy for the same reason, really, because we've stimulated potentially more eggs to move into the fallopian tubes than normal. So there is a risk of ectopic pregnancy, which obviously poses a distinct risk to life of the mother. So potentially we could have seen that on a scan, although by 12 weeks, I'd expect the patient to be having symptoms if they had an ectopic pregnancy. So that's our second case. Any questions on that one, or shall we go along to the MCQs? I'm aware of the time, so we'll rattle through our MCQs in not too long, and then we can all head off. But any questions while I'm here? Okay. All right, let's go through then. So here's our first one. If you just pop an answer in the chat when you're ready, just A, B, C, D, E. I might wait for a couple of answers to come through before revealing the answer, and then we can talk a little bit about it if you want to, if we need to. So which of these is not typically associated with Kaposi's sarcoma? So these questions are on a variety of different things. They're all LGBT related. Some are more medical, like this one. Some are a bit more like communication-y. This one isn't particularly easy either. I'd say it's harder than most of the other ones. So I'll remind you while you're thinking about it. So Kaposi's sarcoma is one of the most common tumors associated with people with HIV. And it became widely known as one of the AIDS-defining illnesses. So the Center for Disease Control advised it as it can be used worldwide as a guideline for an AIDS diagnosis. So if someone presents with Kaposi's sarcoma. So any thoughts on the answer? Nobody. Okay. C. Okay, thank you. Anybody else? Thank you, Kimberly, for being brave enough to say something. So it's a soft tissue sarcoma. It often affects the skin and the lymph nodes in the mouth. And usually high active antiretroviral therapy will prevent it and often treat it, to be honest. Okay, so only Kimberly. Well, you were spot on, dry cough. So purple lesions are like the classic appearance that you'd recognize it as. It's associated with human herpes virus 8. So yeah, exactly. C was the right answer. How should we treat trans patients in the hospital? What do we think? D? Okay, thank you. Anybody else? D? Yeah. Yeah, D. Cool. Good. That's a relief. Yes. Ask a patient their preferred pronouns. I'm really glad none of you said any of the other ones. Yeah. So make sure that your clinic areas are set up well for patients. Make sure that their wristbands, if they've got a wristband with their identification on it, if it has the wrong stuff on it, try and get that changed. Double check with the nurse in charge. Can we put their wristband maybe like somewhere a bit out of the way where the nurses can find it when they need to give drugs to confirm patient identity, but not where the patient has to look at it 24/7, because that won't do them any good. Okay, which is true with regards to fertility preservation in transgender women? What do we think? A, B, C, D, or E? Hey, okay. Anyone else got any thoughts? Thank you for giving us an answer to this, Sinead. Okay, I'll put you out of your misery. Yeah, A is exactly right. So they must stop estrogen for 3 to 6 months prior. So the option D, the max storage time. So the maximum storage time is actually 55 years, but the standard is 10 years. And after that, patients must write to the clinic to request if they want it stored for longer, and then a doctor will assess if they feel there are medical grounds to continue storing, basically. So I think it's unlikely someone would have their tissue, their gametes stored for like longer than 20 years, probably, just because of when they would have stored them, and then the age in which people tend to become parents. So they'll probably use them by then. Okay, what is a best practice for sexual health screenings in LGBTQ plus patients? B? Okay, anybody else? B? Yeah. Yeah, again, I think that's pretty clear, isn't it? It's definitely B. Use inclusive language. when asking about sexual history and behaviors. What is a key factor in reducing healthcare disparities for queer patients? B? B? Yeah, again, definitely B. I think E is an interesting one, isn't it? Because at first glance, it sounds like that's right. Treat all patients the same. We don't care about your identity. We'll all treat you all the same. But actually, we might need to treat patients with minority identities in more sensitive ways, right? So actually, that's not the same. But what that doesn't mean is treating them worse than other patients. So which of these is true with regards to post-exposure prophylaxis for HIV? So I remind you, PEP is used after the virus has entered the body. A? Yeah. Yeah. I think it's A. Oh, my cursor's gone missing. There we are. It should be given as early as possible, definitely. It's obviously not only used for healthcare workers. It definitely doesn't provide 100% protection. Usually you can get it through sexual health clinics or through A&E if it's out of hours. You can't tend to get it from GP surgeries though. And if a patient has had sex with someone with an undetectable viral load, they won't actually need PEP because it won't have been passed on. Which is true with regards to nursing a newborn. What do we think? B, technically with medications. Okay, any other thoughts as well as B? No other takers? Yeah, I'd agree. Yeah, exactly. So using medications, lactation can be induced, and then they're able to breastfeed a child they didn't give birth to. Which of these gender affirming treatments isn't available on the NHS? If you don't know where any of them are, by the way, just let me know, and I can answer. We've got a B. Okay. Anybody else? B. Yeah. Yeah, exactly. Facial feminization surgery is not covered. However, all the others are. Okay. Surrogate rights. What do surrogate rights include? E. Okay. Anybody else? E. Yeah, exactly. It's all of them. I think some of them definitely surprised me. Like the 52 weeks of maternity leave surprised me. The partner also having shared parental responsibility. Interesting, isn't it? But yeah, that's right. All of the above are true. And then this is I think this is the last one. So which statement of the below is true? If you're not certain what I mean by permanent or not permanent, then let me know and I will explain. A. Okay. Anyone else got any thoughts as well as A? Don't worry about getting it wrong. That's why we're here, to just learn about it. So do give it a stab. B. Okay. Anybody else got thoughts? So this one is definitely a tricky one. So by permanent, what do I mean? I mean, if the patient stops taking that hormone, does the change stay? So that's what we mean by permanent or not permanent. So let's look at the right answer and then I'll explain why. As if they stop taking estrogen. Yeah, exactly. So if the patient stops taking estrogen or if the patient stops taking testosterone. Any advances on those two then? Since there was a question before I reveal the right answer. No? Okay. Okay, so the right answer is D. So we'll go through them quickly. So breast growth, that one is permanent. If they stop taking estrogen, then that's not going to like recede, if you will. However, change in body odor, it will stay while the patient is taking the estrogen, but it will if they stop taking it and they make their like endogenous testosterone again, then their body odor will change back. The pitch of their voice, unfortunately for trans women, estrogen doesn't change the pitch of their voice. Trans women tend to either have no change to their voice, and if that's what they're happy with, then obviously that's fine. Some trans women will have like voice training to try and increase their pitch. D, so if people take testosterone, so fat redistribution in trans men refers to fat moving from like the hips and the bum and the breasts and moving more into the center of the body, so onto the abdomen. So that will happen when they're taking testosterone, but then if they stop, then that fat will move back into those more like female places to hold fat. And then the increase in libido, so the increase in libido will be there when they're taking testosterone again, but when they stop taking it, then that will go back down. So that's the explanation for that one. Yeah, a bit of a tricky one, but that's everything. Thank you so much, everybody, for sticking around. I've got a feedback form there, the QR code. please fill it in. It'd be really helpful. I'm doing a QI project into the teaching of LGBT medical education because I want it to improve. So it'd be really useful. If you've got any questions, then feel free to drop them in the chat now. I'm happy to stick around and answer. And thank you as well for staying on a bit longer than I expected us to. And as I said before, if you're available, do pop along tomorrow evening, 8 to 9 again, to look at children and the elderly. That will be run by Dr. Fatima Rashani. She's an F1 working up in the north of England. I'm just going to stick around for a minute or so that the QR code stays on the screen. But yeah, thank you all so much for coming and have a wonderful rest of your evening. Okay, thanks very much, everybody.